His Excellency, dear guests, dear colleagues, friends, ladies and gentlemen, we all want to live a long and healthy life. But unfortunately, we have on this way rocks and reefs in the form of various serious diseases. In many cases, we can avoid them or prevent them or detect them as early as possible to minimize their impact. I have now treated cancer patients 30 years, but I've always known that the best cancer cases are those we can prevent, or if not possible to prevent, detect as early as possible to minimize their impact. So imagine the future when we can precisely detect our personal risks for serious diseases and using this knowledge to reduce their impact. And that's the topic of today's our international session here, where we have presenters from 3 countries who very much share same visions in this field. But let me please allow start from my presentation. So a little bit about our background. As you heard from Professor Tõnisson's presentation, we have in Estonia already 20 years national biobank. But later, 2015, our government started such first preliminary analysis, how to exactly use this information in healthcare. How to move from research to real-life clinical applications. And in 2015, we had national preliminary study in these topics, which resulted in national feasibility or pilot project 2017 to 2021. We researched how in real life bring biobank data into use in the example of breast cancer and cardiovascular disease. I had the honor to be first the chairman of this consortium who performed this study, and I was principal investigator of breast cancer part. But during this project, we understand that if we believe in these technologies and approaches, then we have to move from research to actual real life to healthcare. But according to European regulations, genetic information is possible to give on clinical grade level only if this is according to healthcare regulations, which demand that genetic tests are so-called CE-marked in vitro devices in European market. And we need manufacturers for these tests. And therefore, we created company Antegenes. We had 2 years research, validations, developments, creation of technical documentations, but very importantly also creation of evidence-based clinical recommendations and programs based on risk levels. And 2020, we brought to the European market the first CE-marked in vitro device-level tests using polygenic risk score technologies. And 2 years later, from this year, Estonian National Public Breast Cancer Screening Program has accepted polygenic risk score levels and as the entrance to public screening program. So Antegenes is a digital health tech company and also medical lab and healthcare services provider in Europe. And our aim has been all the time to bring polygenic risk or technology, which is new for healthcare, into use according to healthcare regulations, demands, and also creating clinical utility. What problem we are solving? You all know that cancers are most deadly diseases globally, and the problem is actually increasing. But what we can do with these serious problems? As I said, we can prevent them or detect as early as possible. But actually, current cancer screening programs only consider age as a risk factor. And we know nowadays that actually our risks are very different, and a lot comes from genetic background. So we can say that current screening programs, they are not precise, not efficient enough, and they are outdated. What could be the solution? Here, one example. In case of breast cancer, we know that early detection saves lives. If we look for European data, we see that this high column everywhere are survival of patients with early disease. And low columns everywhere are survival numbers for advanced disease. You can see big difference here. And same time, we know that half of breast cancer cases in Europe are not detected in early stage, almost everywhere. So it's the global problem. My talk today is focused especially for breast cancer, but actually same logics apply to other common cancer types like prostate cancer, colorectal cancer, and others. The solution could be that we have to make the screening more precise. We know that with screening we can reduce breast cancer mortality 20 to 40%. But in most European countries, screening is started from age 50, and there is no such evidence and support that at the earlier age is beneficial to screen all women, because screening has also harms and also costs. For example, in Estonia, we have screening from 50 to 69, but you can see these columns are primary breast cancer cases in Estonia, and you can see that a lot of cases are outside of this screening group. If we look internationally, you can see same picture in United Kingdom, where a lot of cases are under age 50. And if we look for data about United Arab Emirates, we saw quite similar picture actually, that in Emirates screening is, due to our knowledge, from age 40, but still there are a lot of cases among younger women. So what could be the solution? Solution could be such more precise, personalized screening, where we can consider our risk levels, but we need tools for that. Same time, we know from studies that genetic predisposition plays a significant role in our risks for cancers. Not all comes from genes. Very important are also health behavior, lifestyle, and so on. But still, we have different basic risks comes from genetic predispositions. As Professor Tõnisson showed, we know already a long time that there are so-called monogenic or single gene mutations, which like BRCA1, BRCA2, on the left side here, they have significant carriers of these genetic changes. They have significantly higher risk level. But actually, this horizontal line shows that they are relatively rare. Same time, we know that there are a lot of single nucleotide polymorphisms, such common variants in genes, which also have impact for disease risks. Each of them individually has very small impact, but if to summarize them together, then the differences of risks become already significant. And it's possible to analyze with technology called polygenic risk scores, which summarize into single score impact of hundreds, thousands, or even millions of SNPs. If we look for Estonian data, using data from Estonian Biobank and also from our analysis, then we can see in Estonian population, we have 2% of women who have high or moderate breast cancer risk from single gene mutations. But we have 20% of women who have moderate to high polygenic breast cancer risk. So nowadays we can say that that genetic testing without considering polygenic risk scores is not up-to-date approach anymore. Antegenes has developed 4 tests on CE-marked in vitro devices level into healthcare for breast cancer, prostate cancer, colorectal cancer, and skin melanoma. And they are validated using United Kingdom Biobank data, and also in case of breast and prostate cancers, Estonian Biobank data. So we can say that in working this out, we had also cooperative project with University of Tartu, and we can say that this was also such international cooperation with UK Biobank. Here you can see example of risk differentiation in case of breast cancer. These are probabilities, 10-year probabilities for breast cancer. This green line here is Estonian average. If we become older, then the risk is higher always. But we can see that there are high-risk groups of women and low-risk groups. So actually, the risks are very different for breast cancer. So principally, this is the model. If we can evaluate our genetic predispositions, then we can give more precise recommendations for screening. We can implement the personalized screening programs, and with that we can reduce mortality and morbidity from these common diseases. This is such complex model how our process works. So, of course, the first step is information and consent from patient or actually healthy individual. And we are using for polygenic risk scores technology which is called genotyping, because all biobank information in Estonia is analyzed mostly using this genotyping technology. And the sources for genetic data could be both biobank data, which are already available. But for those who are not biobank participants, we do new genotyping using our either university lab or our partner labs in Europe. And then Antegenes software creates risk reports which go directly to patients, but they are going also into our national e-health information system to patient portal. And from this source, patients, doctors can also see the reports, the recommendations, and then they can apply for their patients clinical programs for precision prevention. As I said earlier, from this year, Estonian public health insurance decided to include polygenic risk score reports into national public breast cancer screening program as a starting point for high-risk younger women into screening. And due to our knowledge, we can say that Estonia is the first country in the world who has implemented such solutions based on polygenic risk scores into national screening program. So our such overall model currently bases on our feasibility or pilot project in Estonia, which had also component of cost efficiency analysis. And this study showed that if to analyze monogenic, or as our British colleagues call them strong gene mutations for all people, it gives clinical benefit, but current prices are too high for that currently. So it's recommended currently in Estonia for those individuals who have certain pre-specified criteria, mostly family history, family cancer history. Polygenic risk scores, they are not dependent so much from family history, and they are recommended for everybody. And the testing is currently much cheaper than in case of monogenic mutations. We are giving also such complex of information from this analysis. When to start screening, how to start screening. For example, to do mammography every year, or in case of low risk, after every 2 years. In case of very high risk, we recommend using magnet resonance imaging. In case of high risk, we also recommend hormonal chemoprevention. And also, we give always in our reports health behavior recommendation, because as I said, not all information comes from genes or risks. And also we give information about body awareness, which is information about the possible early signs of tumors. Here is principally the model for current precision screening. In the vertical line is age, and from age 50, all women are invited to screening currently. And this orange line is screening for based on risk estimations. So we invite women who have higher risk at early age than average risk in age 50. Societies have agreed that the average risk at age 50 is good enough to start screening, but actually many women have a similar or higher risk already at a younger age. We performed last year more than 10,000 tests, polygenic risk score tests in Estonia, and our data showed that 2 times higher risk level was in 7.4% of women, and more than 3 times higher in 1.6% of women. But in average, we saw that up to 40% of women actually should start screening at early age at 50. Of course, now if we are going into broader implementation, then we have a question about ethnic backgrounds. Because of current genome-wide association studies have been formed mostly in population with European origin. And Antegenes has started and performed already research development project to adjust different risk levels among different ethnic groups. And we have used so far data from UK Biobank, also published open research data, and we have generated currently for UK market adjustments based on different ethnic background informations. But of course, we see here a lot of topics for future research and possibly also such international cooperations in this field. Antegenes is currently performing two quite big projects in European healthcare with international partners in academia, hospitals, and also industries in Norway, Sweden, Portugal, and other countries. And of course, these projects also include some question of implementation of different ethnicities. And we, of course, are looking partners also in other countries to develop such approaches in cooperation globally. As conclusion, we can say that the future of precision personalized medicine in healthcare in some diseases is already here, and hopefully more complex, precise, personalized prevention of many diseases is not so far away. Thank you very much for your attention, and we plan so that we have questions and discussions at the end of our session.